Hello, everyone. My name is Meena Ramchandani. I'm an infectious disease physician at the University of Washington in Seattle. This podcast is dedicated to an STI review for healthcare professionals who are interested in remaining up to date on the diagnosis, management, and prevention of STIs. We are excited to welcome Dr. Eric Chow for this episode to discuss HPV and HPV vaccination. Dr. Chow is an STI epidemiologist and biostatistician based at the Melbourne Sexual Health Centre in Australia. He heads the Health Data Management and Biostatistics Unit and is a professor at Monash University. Dr. Chow's research program aims to improve the treatment, prevention, and control of STIs with a particular focus on gonorrhea and human papillomavirus, or HPV. And to all our regular listeners, Dr. Chow led the randomized control trials to evaluate whether mouthwash would work to treat or to prevent gonorrhea, which we reviewed in our August 2021 episode and is one of our most listened episodes. In this particular episode, we're going to focus on his work related to HPV. Welcome, Eric. Thank you so much for being on this episode.
It's my pleasure to be here. Thanks for inviting me.
What is HPV and what does it cause?
So HPV is a very common virus that can spread through skin-to-skin contact, and this also includes sexual activities. So HPV can affect all genders, like both boys and girls, male and female. It has been estimated that about 85% of female and 91% of male will get an HPV infection during their lifetime. And we know there are probably more than 200 different types of HPV, and many do not cause symptoms, but some will do. So some HPV will cause wart or pre-cancer lesions. For example, we have low-risk HPV type 6 and 11 that actually cause 90% of genital wart. And while high-risk types such as 16 and 18 that can also cause cancer. And about 70% of cervical or anal cancer are caused by these two high-risk types, 16 and 18.
So there's lots of HPV serotypes. Some of them don't really cause disease, and the patient's immune system or the person's immune system can overcome that HPV, but there are particular serotypes that lead to either warts or to cancer, correct?
Yes, that is correct.
And then what are the benefits of the HPV vaccines and why is it recommended?
I think we are very fortunate to have HPV vaccine available. So the HPV vaccine can actually protect us from getting serious outcome and also can also protect the community by reducing the spread of the disease. And can also protect you from a range of different cancer and also disease that caused by HPV. And we know that since we have the HPV vaccine and there are lots of different clinical trials and also population level study have also shown a reduction in HPV infection and related disease.
And so who should be vaccinated against HPV? What are the recommendations, at least in Australia?
Well, I think ideally, everyone should get the HPV vaccine. And when I say everyone, this is including both men and women. So it is better to get the vaccine before they become sexually active because we know the vaccine has a better protection when it is given before someone is exposed to the virus.
And so who is getting the HPV vaccine in Australia?
So Australia, we have a school-based program, and both school boys and school girls aged 12 to 13 will get the free HPV vaccine, and this is part of the National Immunization program.
Can you tell us a little bit about the different vaccines available for HPV in Australia and the different serotypes they might protect against?
So right now we have 3 different HPV vaccine on the market. So first we have the bivalent vaccine, which protect against the 2 high-risk type 16 and 18. And next we have the quadrivalent vaccine, which not only cover the 2 high-risk type, but also the 2 low-risk type 6 and 11, which cause the genital wart or anal warts that I just mentioned. And finally, we have the non-valent vaccine, which also provide protection against the 9 different HPV type.
Okay, so we have the 4-valent vaccine, which prevents against serotypes that cause the highest number of cervical or different types of cancers, as well as some serotypes that cause genital warts. And then the 9-valent type which has an expanded set of HPV serotypes it protects against, correct?
Yeah, that's correct.
So you mentioned the National School-Based HPV Vaccination Program. Tell us a little bit more about this program. When did it start and what led to the program being implemented?
Australia was one of the very first country in the world to introduce the school-based HPV vaccination program, and which make the vaccine free for teenagers through the National Immunization Program. So right now, teenagers aged 12 to 13 years old can also get the HPV vaccine for free at school. They can also go to doctors, local council, and also even pharmacy to get the vaccine.
And what if they don't get it through that program? Is there a catch-up vaccination program?
The HPV vaccination program started back in 2007 and initially for school girls for age 12 to 13 years old. And we did have a catch-up program for young women aged up to 26, but that catch-up program was only run until 2009. And we currently don't really have any other catch-up program. And I forgot to mention that the program actually expanded to include boys in 2013. So this gender neutral approach actually helped to ensure everyone, regardless of gender, to get protected from HPV.
Now, Australia is pretty unique in that this was really the first national school-based program. What led to the school-based vaccination program being implemented and how was it implemented? It's pretty amazing to be able to vaccinate such a large number of individuals from getting cancer in the future.
I think we very fortunate that our government actually made the decision to implement this school-based program. And this is basically based on scientific evidence, and it actually showed very effective and also protect against serious conditions such as cancer. And it's actually rolled out through school. So usually they have education to the teenagers and also some education and packages to the parents and also the kids understand what HPV is and also the benefits of having the HPV vaccine.
And what type of education do you do with the school-based children and with the parents?
I think it varies. So there are lots of official education, like the printed material or some YouTube video that can be provided to both the kids and the parents. But also some school will probably have a school nurse and they can also provide some additional education in terms of not just HPV, but maybe related to other health or sexual health education.
And so what has been the vaccination uptake across jurisdictions?
It has been really high over the decade, so it's also very good to see it's very similar for both boys and girls. So I just looked up the data back in 2023. So about 86% of girls and 83% of boys turning 15 have been vaccinated against HPV. So 86 and 83 is very similar number in both genders, so which is really good to see.
Yeah, that's fantastic. Were there any barriers that you know of to vaccination uptake and how was that overcome?
Yeah, I think for the vaccine was first introduced, some people were very hesitant. I think mainly because they worry about the vaccine safety. But over the decade of education and also we had a lot of awareness campaign, this is probably not the big issue anymore. But we do know there's some gaps in vaccine coverage, and this is probably mostly due to whether they can access to the vaccine, and also sometimes may probably due to the cultural and also relational reason that they may not want the vaccine. So this is probably the major gap and major challenge that we'll probably need to deal with, particularly with people living in remote and rural area that may have limited access to healthcare services and also the vaccine as well.
How many doses are administered of the vaccine? Are you doing 3 doses or 2 doses? And then did you find that when you went from 3 doses to 2 doses, if you did that increase uptake or make it easier for individuals?
This is a very, very complicated question because we actually changed quite a few times. So From 2007 to 2017, so a decade, so we used the three-dose quadrivalent vaccine. That is the vaccine that covers four types. So in 2018, we switched from the three doses quadrivalent to two doses non-valent, which cover the 9 type of vaccine. And more recently, in 2023, we dropped it to one dose, the non-valent. So it has been quite a bit of changes over time. But also, like if people have a weakened immune system, we still recommend them to have 3 doses. I think the changes is very recent, so we'll probably need to wait a bit more time to see the impact about 2 doses versus 1 doses. We have a long history of 3 doses vaccine.
So it's really only 1 dose that can really reduce barriers to people getting the vaccine because they don't have to come back for subsequent vaccination.
Correct. And also the coverage is also a bit tricky to calculate, as you mentioned, because previously they calculate complete dose, which is 3 doses and then 2 doses and then 1 doses, but we didn't actually see much decrease, and it's actually slightly increased, but it's just very difficult to compare because you're comparing 1, 2, and 3 doses over time. But having 1 doses and the coverage was about 85%, which is really good, I think.
When the vaccine education is being discussed with families or with school-based children, how is it being discussed? Is it a way that this vaccine will prevent against cancer? When talking to parents, is it about sexual health or STIs? Where is the emphasis, or is it a combination?
I think different schools doing different things. So from the national perspective, we actually focus on the cancer prevention. So it doesn't really mention anything about STI. So some school may, but I'm not entirely sure how the school will do the education. But at a national level with the material, it's always mentioned about cancer.
So it's a cancer prevention vaccine.
Yeah.
And that's really where the focus is. That's really helpful. What has been the impact of the national vaccination program on HPV prevalence?
I think the impact of the national HPV program on HPV prevalence has been massive. So we actually have quite a lot of different studies showing a dramatic drop in HPV vaccine type among those people who have been vaccinated, particularly those people in the younger age and also Australian-born people who were eligible for the vaccine.
And has this impacted HPV prevalence for serotypes formulated in the vaccine? And what about serotypes that are not part of the vaccine?
Yes, so we did a study looking at probably 10 years of a cohort of men and women coming to our sexual health clinic with chlamydia. And we actually find that for female with chlamydia, we compare the HPV type before the vaccination and after the vaccination period. And we saw a 54% reduction in HPV that cover in the vaccine. And we also saw a very similar reduction in heterosexual men as well. It's about 60%. And I just want to point out that because this cohort is individual coming to the STI clinic and they're very sexually active and they're also at a higher risk of HPV. So compared to the general population, so that means the actual impact of the vaccination program may be even higher than what we have observed. And back to your question, for those genotype that is not covered in the vaccine, and in the same study, we actually didn't see any changes or decline or even increase in those type. So, which is also a really good news that you actually reduce the vaccine type but may have an increased risk to other types. So I think this is actually evidence showing the vaccine actually works really well and also protect against some high risk and also low risk type that may cause serious outcome.
Do you think that there's potentially some sort of immune response that's being elicited by the vaccine that protects people from HPV, whether it's HPV serotypes in the vaccine versus even serotypes that are not part of the vaccine?
Yeah, there has been lots of discussion, and I don't think we still quite understand that could be potential, but looks like we don't really have any at risk of having other higher prevalence among those vaccine type that is not covered in the vaccine.
What has been the impact on high-grade cervical disease and genital warts?
I may probably start with genital warts first, which is easier. So in Australia, we have set up this national surveillance network, which actually track cases of genital wart across about 40 sexual health clinics in Australia. So a few years ago, we actually published a study looking at a national impact examining genital wart trend over time. And we actually found that genital wart has dropped about 58% in female and 45% in heterosexual men, which is very, very promising since we start our HPV vaccination program in 2007. And also just want to remind everyone that the boys were not included in the school-based program until 2013. So most of these men were not vaccinated. And the reduction we saw in this population is called herd protection or herd effect. That actually means that these men were not directly vaccinated, but they still get the benefits from their female partners because the fewer people around them carrying the virus.
What about high-grade cervical disease? That might be harder to study because it's a longer time before you can see that impact, right?
So we do have some national data from Australia showing a big drop in high-grade disease in women who were eligible for the HPV vaccine. I think the biggest or fastest reduction was seen in the youngest group. And for example, before the vaccination, it is estimated that about 14 out of every 1,000 women screened had a high-grade lesion or high-grade disease. But now it actually dropped down to 5 cases per 1,000 women screened. So we definitely see a huge reduction among these women. And we didn't see this kind of reduction in women that were not eligible for the vaccine. So definitely is the impact from the vaccine.
And the fact that you're not seeing an increase in other serotypes even makes it more of an impact because it's not like it's being replaced by other serotypes that could cause genital warts or high-grade cervical disease.
Correct. There's also some data on cervical cancer incidence that actually show a significant drop after we introduced the HPV vaccine program. And I actually look up some data. So they actually said back in the 1982, the age standardized incidence rate was 16 cases per 100,000 women, and it dropped down to about 8 cases per 100,000 women in 2022. So it's actually half of the incidence. So very, very promising.
Have you looked at other types of cancers that are HPV related? For example, the potential impact on HPV related oropharyngeal cancer or anal cancer or penile cancer?
I would love to look at those cancers to see whether there's any impact from the vaccination program, but it's also very challenging to track those cancer. This is because it usually takes decades to develop the cases. But we do have some study actually showing reduction in HPV in those sites, including the oropharyngeal and also the penile area. So if we see a very similar reduction in the HPV type that can cause cancer at those sites, I can't see why we are not seeing a reduction in cancer, but you probably just need to take time for us to look at the impact and also to get the data.
Mm-hmm. And you, I imagine, are going to look at the impact of the 9-valent vaccine compared to the 4-valent vaccine. And I wonder if that's going to adjust the impact as well over time.
It will be quite challenging for us to look at different vaccine and also different doses as well. So it's a really good point, yeah.
What about mortality from HPV-related cancers? Has there been any data to suggest that there's been an impact on that?
So we do have some national data has shown that the number of deaths from cervical cancer decreased over time and over the same period from 1982. So the death rate decreased from 6.2 deaths per 100,000 women to 2 deaths per 100,000 women in 2022. So definitely a very good improvement to save lots of lives.
That's a big deal. Now, you mentioned the herd effect. For our audience, can you describe the herd effect? And you mentioned that there has been a reduction in HPV prevalence that might have been an impact of the herd effect. How about genital warts or cancers or impact on cervical disease?
So herd effect means those people who were not vaccinated actually get some benefit from their vaccinated partners because those vaccinated partners will have a lower prevalence or lower rates of certain disease, so they will be less likely to get the infection or disease. But there's actually a condition that would probably need a fairly high vaccination rate in the population in order to create this herd protection. And most of the study that we did was only looking at genital warts because it's a proxy that we can actually use as an outcome. We also did some study on HPV prevalence as well. So we also see reduction in HPV prevalence among those who were not vaccinated, but their female partners got vaccinated and with the vaccine type. So we did see a reduction in those type. I'm not aware of any study looking at herd protection for cervical disease and cancer. And again, it may probably need some time to get data.
This has really had a huge impact on the community, this school-based vaccination program, in a much larger way that potentially had even been anticipated.
Yes, because with the female-only school-based program, we already saw a very significant reduction in heterosexual men. And also, we do have some data when we add the gender-neutral program, we also saw a further reduction, particularly in men. And also, because female has been really, really low, so it still remains low, but I think it's really important, like for the gender neutral program, we need to remind ourselves that there's some other populations, such as gay men, they probably won't receive the same benefit as heterosexual men due to their sexual preference. And most gay men were not vaccinated, so they probably won't get the same protection. We didn't see any reduction in genital warts and HPV prevalence in gay men during the female-only vaccination program. So this is actually not only making the vaccine more inclusive, like to have both gender, to have the protection against HPV, but also even when we're talking about heterosexual men, that the heterosexual man can get the vaccine, can also protect against their female partner if the female is not vaccinated. So it's kind of like a win-win situation. It can actually protect the entire community.
Do you know of other countries who also implemented a national HPV vaccination program based on the experience from Australia, since you guys were the first ones?
I think the US was the first one, technically. But yeah, we're very, very close. One of the very first few ones. Lots of countries, I think, have followed. I think, including the UK and some European countries in the guideline, they also cite our papers and evidence like in their recommendation. But I think different countries may probably implement their vaccine in a different way, depends on the setting. So the coverage and also the different type of vaccine may probably also impact on what they're going to measure at the end as the public health benefit. But I think as of today, I think the WHO reports about 148 countries have already implemented national HPV program. And very, very good to see almost half of them actually to both boys and girls. So it's definitely like improving and hopefully like we're seeing more countries coming on board like to provide a gender neutral national HPV program to the people in the country.
So are you going to measure the impact of the 9-valent now that you have switched over to that? And do you have any data so far of the impact on HPV prevalence or HPV-related disease?
Unfortunately, I don't have any data yet because we only switched to the non-covalent vaccine not until 2018, so it's still very recent and it takes time to see the effect. But we're doing a study currently. So we look at the impact of the bivalent vaccine among young gay and bisexual men who got the vaccine from the school-based program. So these boys would have been vaccinated from school, having the non-covalent 2 doses at school when they were aged 12 to 13. So in this study, we collect samples from the mouth, genital, and anal area, and then we send the samples to the lab for HPV testing. And then we can compare the HPV prevalence because this is the third cohort that we are doing. The first cohort was people who were not vaccinated. Second cohort was vaccinated against the quadrivalent type, and this cohort would have been vaccinated for the bivalent type. So we'll have 3 different cohorts to compare the prevalence. We plan to finish recruiting by the end of this year. It has been very challenging for recruitment because they're very young, age 16 to 20, so very difficult to get them to the clinic and also do extra swab. So fingers crossed, hopefully we will have some data to share sometime next year. So stay tuned with us.
I look forward to seeing that data. Are there any other areas that you're going to be evaluating for the impact of the national school-based HPV vaccination program?
So we also planning to do some surveillance, particularly from the genital ward surveillance that I mentioned. The previous genital ward surveillance that I mentioned was only focusing on women and heterosexual men, but we haven't done any study on gay and bisexual men. But that will be quite challenging because not only the school-based program, but also in Australia, some state also implement some HPV vaccination program for MSM for a very, very short period of time just before COVID. So some state actually offer gay and bisexual men aged up to 26 have free vaccine, having the 3 doses quadrivalent vaccine within a year or 2. And that probably need to bring into the consideration when we did the analysis. So it's on the way.
Based on this data and the data you've gathered, do you think the elimination of a vaccine type HPV disease in Australia seems achievable?
I think so. In 2019, there's a modeling paper from Australia actually predicting the incidence rate of cervical cancer in Australia will far below 4 cases per 100,000 women by 2028.
Wow.
So why they use 4 cases per 100,000 women? This is because this is the threshold that we use in Australia and also in Europe to define a rare cancer. So if we actually push it down to under 4, that means that with the current vaccination program and also the screenings program, Australia could be on track to eliminate cervical cancer by 2028. And also there are lots of other data showing reduction in HPV prevalence in other sites, in penile site and also anal site, that actually show that we may be able to reduce the cancer and also potentially eliminate the cancer. And in terms of genital ward, we have a very successful vaccination program, and then we saw a very, very low prevalence of genital ward. So over the last few years, particularly the youngest group, I think the prevalence of genital ward was less than 1%. So it has been remained really, really low over the last few years in young Australian-born people. So if we actually continue the trend, we may also see near elimination of genital ward. But I should also add, it's not just only the vaccination, it's more complicated than what we thought because people also may have sex with people who are not vaccinated or from countries who are not vaccinated. So this kind of mixing, we call sexual mixing, that makes us unable to really eliminate, but we should actually be able to keep it to a very low prevalence.
What a wonderful achievement already for how much it's decreased the prevalence and the incidence of some of these diseases, but also the future potential. What is the most common question you get about the national vaccination program in Australia?
I just mentioned before, and they probably worried like if they miss out a dose at school, would they actually be eligible like, to get the same dose like somewhere? So yes, you can. So you can actually get it from your primary care, your sexual health doctors, or even pharmacy or local council as well. Some parents may also be concerned about whether it actually trigger their sexual activities, but there are lots of other study showing it doesn't really have any correlation.
Let's talk about a paper that you published in Clinical Infectious Diseases in July of 2022. It was titled Human Papillomavirus Antibody Levels Following Vaccination or Natural Infection Among Young Men Who Have Sex with Men. I thought this was a great article to read. Tell us more about the study and why it was done.
Thank you for that. Yeah, so this study actually looked at two groups of young gay and bisexual men aged 16 to 20 years old. They were all recruited in Melbourne, Australia. And our aim was actually to measure HPV antibodies level in the blood or serum when they received the quadrivalent HPV vaccine at the age of 12 to 13. We also compared this level to those men who were not vaccinated, but they may have been naturally infected with HPV. So the idea was try to figure out like a cutoff value, like to identify people like they can actually have the antibody level from the vaccine or from natural infection. Since gay and bisexual may have a higher risk of HPV-related disease, so it's actually very important like, to understand the threshold, and then we can tell whether this antibody is actually kind of boosted by the vaccine or by the past infection.
What were the main findings of this study?
So we find that men who got the HPV vaccine have a much higher level of antibodies compared to those men who got it from the natural infection. And this is also true for all HPV types that cover in the quadrivalent vaccine, which includes 6, 11, the two lowest type, and also the high risk type 16 and 18. And this is also giving us more evidence that the vaccination leads to a higher antibody level, which have a higher protection compared to natural infection in this population.
Why do you think the antibody levels were higher after vaccination compared with natural infection? Is it because maybe they were getting 3 doses, or what are some of the theories?
I think it's more about like the vaccine can actually boost the immune system to generate more antibodies, and this is probably one of the mechanisms. Also, you're probably right as well. They have 3 doses, and they may probably also act as a booster to generate more antibodies.
And so in the study, how long were antibodies levels sustained in those who were vaccinated compared to those who had natural infection? How long did you follow the cohort for?
In our study, so we looked at the time they had the last vaccine and also the time they had the samples. So the time actually ranged from 27 to 66 months. But we actually find that the antibody can actually last very stable for up to 66 months. So we didn't actually see any changes or drop in antibody level over time.
And that's for those people who received the vaccination?
Correct. So we only look at the people who had the vaccine, and then we did ask them when did they had the last vaccine, and then we look at the period over time. Unfortunately, we can't do this analysis for those people who were not vaccinated because we don't know when did they had the HPV infection.
Was there any correlation between antibody level for each of the 4 HPV serotypes and time since the last HPV vaccine? So, for example, was there a difference between the different serotypes that were present in the vaccine?
In terms of the changes over time or remain stable, it didn't have any differences across the four types. But in terms of the antibody level, we actually saw a much higher level for HPV-16 among those who were vaccinated. And this is also very important because this is the serotype that causes most of the cancer, including cervical and anal cancer.
What are your next areas of research in this field of HPV prevention?
So I think we probably need to still do more surveillance and to understand, as we mentioned, to understand the impact of the changes of different dosage and different vaccine to the population. And also, we know interracial men have a higher rate of HPV-related disease compared to heterosexuals. So we will really need to do more study, do more research to understand the uptake, and because most of them would not have been vaccinated from the school-based program, so and also the catch-up program, and what would be the prevalence of them and what would be the cancer rate in this population compared with those who have been vaccinated from the school-based program.
It's been such a pleasure to have you this episode, and I learned so much from you, and I know our audience is really going to enjoy all your knowledge about these topics. So thank you. Thank you for your time.
Thanks for inviting me.
This podcast is brought to you by the National STD Curriculum, the University of Washington STD Prevention Training Center, and is funded by the Centers for Disease Control and Prevention. Transcripts and references for this podcast series can be found on our website, the National STD Curriculum, at www.std.uw.edu. Thank you for listening and have a wonderful day.